So good afternoon, everyone. My name is Elita Mazzocchi. I am Quality Improvement and Assurance Midwife.
And my name is Joanne Okonkwo, Postnatal Ward Manager.
We are delighted to be here today to talk to you about one of our quality improvement projects linked with the National Attain Programme, aimed to prevent unnecessary admission of term baby into neonatal intensive care unit. By term baby, we refer to any baby who is born 37 weeks, at 37 weeks gestation or above. We will give you a brief overview on the project team, on the National Attain Programme objectives, as well as our local response to it. We also will give you a brief overview of the approach and quality improvement methodologies that we have used as part of this project, and of course, outcome and learning points. But first of all, a bit of background. So we're coming from Queen's Hospital, part of Barking, Havering and Redbridge University Hospital Trust, which is located in Romford, in North-East London region. We have approximately 8,100 deliveries per annum, and we have a level 2 neonatal unit. We are here only as a voice. In fact, the project involved many members of the multidisciplinary team, including neonatologists, obstetrician, midwifery team, as well as nursing team, and actually involved many more staff who supported us in the testing, implementation, and monitoring phases, and this includes service users.
So we decided to focus on this topic following the National Attain Programme, which was launched in 2017. This was following a review of term admissions to NICU. As you can see from the graphs on our slide, the findings showed that despite a decrease in deliveries over the years, the number of babies requiring admission to NICU increased by 30%. This results showed that over 20% of admissions could have actually been avoided. These findings were crucial because, as I'm sure everyone in this room is aware, the avoidable admission of babies to NICU can lead to unnecessary separation of mother and baby. There is an overwhelming amount of evidence that suggests that when mothers and babies are separated, this can impact on bonding and attachment of the mother and baby, which can impact on the mother's mental health, also the neonatal development of the neonate as well. So, the National Attain Programme focused on 4 key areas significant to prevent potential harm of babies. These were respiratory conditions, hypoglycemia, jaundice, and asphyxia. They looked into these areas because respiratory conditions, we found in their findings, showed that over 33% of all represented 33% of all NICU admissions, and it was the most common cause of a baby being admitted to NICU. Followed by hypoglycemia in babies. This was also very common, particularly in babies born via cesarean section. Possible interpartum asphyxia was also highlighted, one of the most common causes of admission to NICU, and also jaundice. This was by far the most common cause of admission from home. So, also, transitional care. So, in addition to this, they looked into improving the care of babies who could have been managed in another setting. So this be at home, in the community, or a transitional care setting. This would mean that the baby would not require admission to NICU. So we can ask, what is transitional care? So based on NHS England definition, transitional care is a service, not a physical space. This enables a mother and baby to remain together, but enables the baby to require the additional support and treatment the baby needs. This can be delivered, as I said, anywhere, so long the 4 principles we have identified are adhered to. Following this review, NHS England published a patient safety alert and many other reports and resources to support maternity units and neonatal units across the country in this matter.
Looking at our local response to the national attain alert, first of all, we set up a multidisciplinary project team with the aim of meeting monthly to review our current practice, system and processes and set possible recommendation and quality improvement initiative in order to improve maternal and neonatal outcome as well as prevent any possible avoidable admission to NICU. This translated into a local attain improvement plan, which included over 50 recommendations, which varied from actually generate new idea and new innovative and more user-friendly pathway of care, increase awareness of staff on the importance of this topic, looking at the staffing level for maternity, for neonatal intensive care unit, as well as for the transitional care setting. Recommendations were also around review the communication and the working relationship between maternity and NICU teams, which would enable us to have a better understanding of our organizational culture. Looking at also training available for maternity and NICU staff, our governance arrangement, physical spaces and service location provided. We also had, as part of our recommendation, to share our experience and our learning with other hospitals, starting from the East London local maternity system. So the local improvement plan was not only informed by the national attain findings, but also from a local review of our own admission to NICU, which aimed to review the resources and review local practice, again, given national standard. And what we found was that actually same as per national, respiratory distress was the commonest cause of NICU admission. We found that on multidisciplinary team review, actually we did provide good postnatal care. However, we found that over 4% of the admission in the time frame that we reviewed were actually potentially avoidable. We also find interesting that over 50% of the baby admitted to NICU actually spent longer time in NICU than we would normally expected. And of course, it gave us room for improvement and actually about other additional 20 recommendations. And actually, our local recommendations were around transitional care facility and how do we ensure we had trained and competent staff in transitional care. Scope some rooming in facility, which we didn't have at the time, which would enable mother and baby to stay together when the baby is admitted to NICU. As well as review jointly governance arrangement, including guideline and policy, and education for staff. What we did change based on the 2017 review was, firstly, we reviewed a number of pathway of care which were agreed by maternity and NICU team. And this was actually an innovation because we found that actually between the two teams we had maybe conflicting guideline and conflicting information. One example is the lumbar puncture pathway. So following this review, now we perform lumbar puncture in our postnatal transitional care settings. Another example is IV antibiotics to babies. So we standardize the pathway for IV antibiotics to ensure a set time frame and process. This is aimed to minimize antibiotics delay to newborn. Also, we develop a new pathway by which NICU team actually attend the maternity and the transitional care setting rather than us bringing the baby to NICU, again separating possibly mother and baby. We also reviewed our newborn early warning score process and our escalation process to ensure all staff were aware and trained on this topic. As we say, we developed then new agreed jointly policy and guideline. We also look at staffing, so we fully staff a transitional care facility, and we also produce competency pack and training for the staff working in these settings. We were able to commission 2 rooming-in facilities, which actually are now in use. And also, all the work was really around breaking down barriers between maternity and neonatal teams. So a year down the line, we perform another look-back exercise to see where we are now in 2018-19. So we conducted a retrospective and systematic data review of all term admission between October 2018 to February 2019. We collect data from several electronic systems, including K2 and BudgeNet, as well as unheld antenatal, postnatal, and neonatal health records. Key in our project for this year was the woman involvement, which was actually lacking in 2017 project. So we worked very closely with our Maternity Voice partnership, and we included in this year review actually the women direct feedback of the care provided in the postnatal setting. This gave us a unique insight of women perception of the safety and of the separation with their baby while in care. So we had multiple objectives, but the key one was actually to evaluate the changes and the implementation of 2017 and see if actually these ones were still meeting the service and the user needs. We had some limitation in our review due to the nature of the topic. Of course, we had a limited sample size of 56. As you are probably aware, NHS England published a TAIN audit tool which actually focused differently from 2017 also on the impact of antenatal and intrapartum care and their possible link to the admission to NICU of the baby after delivery. And of course, as the TAIN new audit tool has just been published, we don't have at the moment external comparison available as yet. So let's look at a summary of the outcome. So in the time frame considered, we identified 61 term admission eligible for review. Of these 61, unfortunately, we were unable to retrieve 5 of the health record, therefore these were excluded from the review. The remaining 56, 61% of them, we found that this baby were admitted from delivery suite setting, either labor ward or birth center. The remaining 36% were either from our high-risk postnatal ward or from our low-risk CORA ward, postnatal ward. The remaining 3% was from community. If we look at the main reason for admission of term baby to neonatal unit, we found again for the second year, and same as the national ATTAIN findings, that respiratory distress remain the commonest reason for admission, followed by jaundice, 6%. We then compare our findings with neighboring hospital and with the London ATTAIN findings, and actually we find some similarities. So again, towards London, respiratory distress is the commonest cause for NICU term admission. However, we find some differences, especially with regards to hypoglycemia, which for us actually gave room of example of excellent practice in our unit. So we reviewed the impact of antenatal care to the baby admission, and what we found was that actually no changes in the antenatal management would have prevented the admission in any of the cases that we reviewed. So we were very pleased with these results. With regards to perinatal care, we found that one case in one admission, change in the intrapartum management might have prevented the admission. And actually from this review, a root cause analysis has been launched, and this was related to pathological CTG and some issue around CTG escalation. With regards to postnatal care, again, we were very pleased. The multidisciplinary team on review found that no changes in the postnatal management would have prevented any of the 56 admissions. And if you remember, we just said that in the previous review, over 4% of the admissions were found to be possible or avoidable due to issue in the postnatal care. So it's again an improvement for us. With regards to transitional care, we found that 2 babies could have possibly been discharged earlier from NICU to postnatal ward or transitional care settings. However, as you probably remember, as we just said, in the previous year review, we found that over 65% of babies were actually delayed in being discharged from NICU. So again, room for improvement, however, a big improvement from previous year. Also, we start finding a documentation of the use of rooming in facility, which again is great in order to improve maternal experience when babies are admitted to NICU. We had many lessons learned, as you can see from the slide. And as I said before, they were demonstrating actually a lot of examples of excellent practice, as well as learning lesson and initiative from practice requiring improvement. We were very pleased because this year also we monitored the uptake of the multidisciplinary review of these cases, and actually all the review were conducted as a minimum by a midwife, an obstetric, and a neonatologist team member. Also, majority of the review were conducted, nearly half of them, as part of our maternity serious incident group meeting, where we review the overall care provided to mother and baby to see if this fulfill any need for serious incident or further investigation. As I say, we included women feedback as part of this review, and actually we collect this data on a monthly basis via another national initiative, which is called Safety Thermometer. This is a national tool that allows us and maternity and neonatal service to take a temperature check on harm and harm-free care, and actually to scope immediate action and immediate quality improvement initiative in order to improve maternal and neonatal postnatal care. You might be aware the National Maternity Safety Thermometer is collected once a month, and it was collected from our free postnatal ward settings. And what we found, actually, we were very pleased because majority of the women from January 2018 to February 2019 reported that they were never separated from their baby during their stay, which is also very good news for us.
So, in conclusion, respiratory conditions remained locally our main reason why babies were admitted into our neonatal intensive care unit. And we found that there was a significant improvement in the data that we collected in 2017. Although we were very happy, there's always room for improvement, and we identified that one admission was found to be avoidable if there had been an improvement in the interpartum CTG interpretation and escalation. Following a review of the care of the term babies that were admitted to NICU, 2 babies were identified as potentially they could have been discharged into either step down to a postnatal ward setting or to a transitional care setting. And we were pleased to know that the majority of all of our women had not been separated from their babies during their admission with us in the hospital. So, following on from all of this data we collected, we made some recommendations. The key recommendations was really to maintain the good practice that we had identified that we were currently doing in our trust. But also a key part of our action plan was to ensure that babies who clinically required admission to NICU got there in best of health. So this was looking into things like thermoregulation. So on our labour ward, things that we've implemented is making sure we put a hat on all of our babies, something so grassroots, but it really does have an impact. Also looking at the temperature of our delivery rooms and our theatres and our postnatal wards as well. The next steps we intend on going into is really looking at our preterm admissions. I'm sure majority of people in this room are aware of the national initiative to reduce preterm admissions. So we are looking into magnesium sulfate administration and also steroid administration as well. So we're really excited. We've got some very positive things in our horizons. Thank you so much for listening to us, and we have all of our details there if you'd like to know more. Thank you.
Thank you.
Hi, I just wanted to ask about, you read out the definition from NHS England that transitional care was a pathway, not a setting, but throughout your presentation you talk about a transitional care setting. So did you actually have a setting for it? Did you have identified rooms in your postnatal ward?
I think by what NHS England are trying to say is the setting is up to you, where you want to implement your transitional care. So in our trust, we have transitional care in our NICU. We also have it integrated into our postnatal wards. We have 2 postnatal wards in BHRUT. We've got a lower risk ward and a higher risk ward, and we implement transitional care in both. This is facilitated through us as midwives. This is through our nursery nurses, who are really crucial to delivering this transitional care. But really, I think what they're trying to say is it doesn't have to, for example, be a particular unit, that's where the transitional care is delivered. It can be delivered, integrated into the care we're already delivering, really.
Oh, sorry, I'll stand up. Helen McIntyre. There's a few questions really all in one that kind of go together. One was in relation to your temperature in theatre and what you've actually done with that. Have you managed to turn up, how many degrees you've turned it up, or how you've managed to work that? Okay. The other one was in relation to oxytocin and the use of iatrogenic oxytocin, and how you're going to think about that in relation to its effect on the mother and the babies postnatally. And the third one is about epidurals and opiates in epidurals, and how have any of those been linked into, obviously, baby behaviour patterns?
So to respond to your second and third question, there are very good points. However, they have not been taken into consideration as yet in the review, but good point for future. With regards to the first question, this is part of this year work, and actually we have reviewed the theatre environment because, as you are aware, for infection prevention control policy, we need to keep the temperature on a lower grade. So we are working on it. We are trying to promote, as Joe say, keeping baby warm. There is a lot of work around promoting skin-to-skin in theatre. We are also piloting different barrier, I'm sure you're aware. So it's difficult to change the temperature of the theatre setting, but there are other ways we are trying to see if...
And I think one of the key things is we wanted to know if it's actually a factor. So we've only just got our temperature probes, so it's very, I mean, literally, they're just being plugged in for us to be able to monitor it. We're getting our logs, but we want to know actually, we know, being in theatre, we think it's cold, and we know that one of the biggest reasons why these babies, one of the key places babies go cold from is from theatre and labour ward. So it's actually to determine, is this actually a factor dependent on evidence? And then once we actually find that maybe, yes, it is, we have more really information, evidence to then propel us actually saying, do you know what, we need a whole infrastructure change here, because this is an integrated system with our temperatures, but maybe we need an overhaul because this is a significant factor why our babies are going to NICU cold. So we're in the very preliminary stages, but we are very interested what information we're going to find, really.
Fantastic. I think that's a perfect place to finish. So thank you very much.
Thank you.